Hello, everyone. It's a pleasure to have you with us today. We are very happy to have such a incredible panel of speakers. We would like to thank the support from AbbVie. Uh, uh, we have a wonderful opportunity to share with you important lectures that will discuss prompt intervention in post-stroke spasticity today. We have several lectures. Unfortunately, Dr. Sean Savitz was not able to join. So my name is Otávio Pontes. I'm the editor-in-chief of the World Stroke Academy. I'm going to be hosting the webinar today with you guys. Just some housekeeping rules to start. Please type your questions in the Q&A box in your Zoom control panel. You can use the chat box to say hi, tell us where you're joining from, and leave your feedback, please. This webinar is being recorded, and of course, you can always check and review the wonderful lectures afterwards. And please fill the evaluation survey at the end to get your certificate. We had some previous webinar questions. The first one was how familiar you are with post-stroke spasticity. And we can see here that 42% of the attendants said they have a good understanding, but wants more knowledge about it. And some 38% had basic knowledge. Next one. We also had a question about aspects of post-stroke spasticity of interest. And 32% said that they would like to identify treatment options, 15% overcome intervention barriers, 14% early diagnosis and treatment options, 11% treatment and intervention barriers, and 90% early diagnosis. The other question was about familiarity with evidence-based strategies for post-stroke spasticity. And 41% said they were slightly familiar, 33% moderate familiar, 19% not familiar at all, and 7% very familiar. And the fourth question was use of diagnostic tools for post-stroke spasticity. 42% said they have not used any diagnostic tools. 30% were aware but have not used. 20% use occasionally, and 8% regular use in clinical practice diagnostic tool for post-stroke spasticity. All right, so now it's my great pleasure to introduce you Dr. Theodore Vane, who is an assistant professor of neurology and neurosurgery and stroke prevention clinic at McGill University Health Center in Canada. And Dr. Vane will talk about introduction into post-stroke spasticity. Thank you so much for joining us.
Do you see me in share mode here?
Yes, we can see your slides. Thank you.
Thank you so much, and it's a pleasure to be here. Good morning, good evening, or good afternoon, depending on where you are in the world. I will be trying to lay the foundation for the subsequent speakers on the incidence, prevalence, and impact of post-stroke spasticity, and why it's such an essential aspect that we need to address in our everyday care. These are my disclosures. I will not be talking about any therapeutic interventions, but really basic science and epidemiology. So I'm beginning my talk because I'm an acute stroke neurologist initially that now works in a long-term stroke prevention clinic and has a marked interest in spasticity. And a number of years ago, my physiotherapist on our stroke unit sent me these two pictures saying that, wow, look at Mr. X here. He's 4 or 5 days after a stroke, and he has marked increased tone. And on the image of him lying on his back of the upper extremity, he has the classic posture of spasticity of an adducted shoulder, a flexed elbow, a flexed wrist, flexed fingers, and what we call a thumb and palm deformity. And with two people needing to get this man up, his leg automatically went into flexion, plantar flexion. You can't really appreciate it, but there's actually an equinovarus foot response here. And so it brought this to my attention is like, what is the evolution of spasticity? Because I always thought of it as a chronic condition. And does it really occur in the acute stroke setting? And what's the prevalence? And should we, and I'm speaking for the stroke neurologist on this call, be much more in tune to this? And does early intervention help prevent this down the road? Because I always looked at this as a long-term chronic condition. So I'm going to go over the definition and incidence of post-stroke spasticity. I'd like to briefly review a layman's view of pathophysiology of spasticity because it's quite complicated. And most importantly, as a clinician, we want to improve patients' quality of life. And what should we know about the impact of spasticity on patients' quality of life? So the definition of spasticity that's used the majority of the time was actually a little bit fortuitously used when Dr. Lance was giving the Robert Wartenberg lecture many years ago in 1980, and he was quoted on this and became the staple for the definition of spasticity, which was he described as a motor disorder characterized by a velocity dependence, so depending on pushing a limb in one direction or the other, that would increase the tone of the ligament associated with hyperreflexia, meaning that there's a central motor nerve system component to it. And he thought this was all a component of an upper motor neuron system. So the concept was that it was a pure motor disorder associated with hyperreflexia. More recently, and it's already a while now, it's some 20 years, Pandayan redefined it and felt that there was a sensory motor control issue that was going on. And this was also a result of an upper motor neuron lesion, but it would cause intermittent or change in contraction of muscles, both positive features with increased level of motor activity, but also would exclude the negative features of paralysis, and that there would also be some biomechanical alterations. So not only thinking about a pure motor disorder, but we're thinking of sensory control of muscle and muscle spindle in combination with changes to joints and soft tissue. Most recently, last week, there was a meeting called Spasticity X that was in Houston, Texas, led by Dr. Gerald Francisco, where they were trying to redefine this disorder and try to purify it a little bit and make it a little bit more applicable to daily use. If we look at the development of spasticity, and my next speaker, Dr. Babakati, this is one of his slides, will be speaking to this, but you usually have an ischemic stroke or hemorrhage, you get cell death and hematoma expansion, and you'll cause injury to the surrounding tissues. This will lead to inflammation and scarring, which is giving our negative aspects of stroke. But what happens then is we have endogenous plasticity that kicks in that first week of stroke. And during that time, we also have improvement and impairment in function. And spasticity is thought to be what we call a maladaptive response to endogenous plasticity, or perhaps spasticity gone wrong. And what actually happens is if we have CNS damage from a stroke, for example, which leads to paresis, will subsequently lead to immobilization and shortening of a position of the arm, so it'll go into flexion. And what happens on the central component is that we have endogenous plasticity in the brain, what we'd call supraspinal, but also at the spinal level, there's argument that things are going on at that level with decreased influence from the central nervous system. And that will lead to muscle overactivity. And we have different types of spasticity. We have the classic spasticity that's associated with changes in tone and is a dynamic process. But we also have individuals who will walk and then will go into a spastic posture, and that's thought to be a spastic dystonia. And we also sometimes have people, as they extend their arm, that may get contraction of their biceps and triceps as you try to do a movement, and we would call that spastic co-contraction. So there's many different aspects to this, and it's quite a dynamic process. And whether all of these different types of spasticity respond the same is not the focus here, but it's something to consider that there's very different dynamic aspects that one needs to look for. But what happens with time, and to me, the failure of identification early on of spasticity and failed treatment, is the development of contracture, because that puts your patient at the worst possible prognostic possibility. And how do we get to contracture? It's really, you have your CNS damage, but you get into this vicious circle of the stroke prevents muscle lengthening, you go into contracture, you get changes in the muscle such as fibrosis, shortening of tendon, soft tissue changes, which leads to abnormal limb posture and then leads to increased tone. And as this continues, at one point, there's enough fibrosis and shortening of tendon that you'll go into a posture of contracture, which will be the most difficult aspect to treat, but really what we aim to prevent in happening. So going back to my initial presentation here, the initial concept of my first slide is, does spasticity occur in the stroke unit or early on? And there's three key trials that are out there. There's many more. I've just selected a few given our time constraints here. Opheim and colleagues found that around 25% of patients at day 3 had a change in tone. Sommerfeld, also from Sweden, found that around 21%, or 1 in 5 patients, were found to have increased tone by day 5.5. So again, something we should be keyed into our acute stroke unit and flag these patients with our rehab team to optimize their functional outcome. And then Jörg Wissel from Germany and Berlin also has demonstrated around a 1 in 4 to 1 in 5 individuals within those first 2 weeks are going to have changes in tone. So it's clearly something that occurs early on. As far as I'm concerned, identification of spasticity should be a performance measure added on to guidelines in the acute stroke setting. So if we look at when does spasticity occur in all of the different trials, it's really quite varied. But if you look at it in less than 1 month, and I just showed you almost 1 in 4 or 5 people happen in those first 2 weeks, on top is mild spasticity. On the bottom here would be severe spasticity. But basically at 6 months, almost 18% will have severe spasticity, which is almost 1 in 5 patients, which is something that we should really try to avoid, because these are the stroke survivors from that 10 to 15% that don't die, and significant number of them are going to have severe disability. And if you look at milder spasticity, which still means it should be treated, that can range up to 63% in those first 6 months, and those numbers obviously present for much longer. What is the impact of spasticity? Well, let's talk about just the mobility itself. It leads to problems with hygiene, increases your risk of osteoporosis. We want to try to avoid fixed contractures. It increases your risk of cardiovascular problems. It can increase the risk of decubiti, so pressure sores, and most importantly, has a huge psychological impact just in your self-esteem and social isolation. So what are we trying to do here is look at what are the consequences. And while it increases the risk of falls, most importantly, impairs our patients' daily functioning. Changes in mobility, changes in limiting hygiene are quite upsetting and frustrating to the patient. Sleep is such an important aspect of basic brain health and is disturbed by spasticity. The altered posture leads to pain, and it makes you work harder when you're trying to do things, as we'll see in later talks on functionality, leading to increased fatigue. So what's the impact to the patient? I'm going to quote this Australian study. We have an Australian speaker coming up. But if you look at the top is what's the impact of spasticity on daily life. So 72% of stroke survivors report that there's impact just on their daily life from the spasticity itself, and almost 50% of them have a loss of independence. Depression and mood alterations are so prevalent, almost 50% as well, and over 1/3 of these individuals who are functional and survive their stroke are impaired by their spasticity and unable to work. Pain remains a marked complication of post-stroke spasticity, and in this study, it's around 36%. As you can see here, but I want to point out that many people report this as high as 60%. And then if you look at basic functionality of the patient, sleep, ability to walk or mobilize or transfer, and even here, family relationship problems are all key aspects of an added burden to a stroke survivor. What's interesting is who takes care of our post-stroke spasticity survivors. And if you look at who provides care for them in this study, 64% of the time it's the family, that the burden of care falls on the family in order to take care of the post-stroke spasticity survivor. 1 in 5 need no support. But I want to point out over here that 7% of individuals require full-time care as a result of their spasticity. What happens to the caregivers? Is there a burden on them? And I want to stress this, why we should be intervening early, not only for the patient, but for the family unit, which is so neglected. So around 35% of individuals have to change their working hours. 15% have to stop working to help take care of someone with post-stroke spasticity. So 50% of people are changing their work schedule or stop working in order to provide care. It's important to note that 15% of individuals of caregivers are not employed due to the older onset of stroke, but over 2/3 of individuals are not going to be able to work or carry out their own lives in order to take care of the post-stroke survivor's life. So what are my takeaway messages here as we prepare for our next talk? When post-stroke spasticity occurs early on and should really be identified in our acute stroke setting, and it's a burden on neurologists to help make that happen. Post-stroke spasticity consistently demonstrates a negative impact on quality of life. In fact, someone with post-stroke spasticity has 4 times the healthcare costs than a stroke survivor without it. And there's physical, social, economic, and most important, psychological factors that should be flagged early on and ensure the right supports are put into place for our patients. As Dr. Bakavadi is going to tell you in the next talk, early intervention and comprehensive management is essential. And my plea to the community as a whole is that systems of care should really monitor for post-stroke spasticity throughout the patient's journey in order to maximize their function. Here are some references that are available on the website. There's some additional resources from the American Heart Association, as well as in Canada. And I'm in the province of Quebec in the French part of Canada, where the Physiotherapist Association actually has a toolbox available in order to help post-stroke spasticity survivors. Should you have any questions, please feel free to contact me, and I thank you for your attention.
All right. Thank you so much, Theodore, for this great talk. We're gonna leave the questions to the end. I also invite you to leave your question in the Q&A session. And now it's my great pleasure to introduce Dr. Ganesh Bhavikati, who is a consultant and clinical lead in neurorehabilitation medicine, based mainly at the Specialist Neurology Hospital, the Walton Center in Liverpool. And Dr. Ganesh will talk about, please share here the slides.
Thank you. I hope you're having a good day. Thank you. We are going to talk about an importance of an early and a prompt diagnosis and intervention in a post-stroke spasticity. We're not talking about the major talk will be on early and prompt diagnosis and why we should do it and how we should do it. This is about the disclosures. So let's focus on the understanding of the importance of early and prompt identification of spasticity and why it matters and why and how that could be an easy or difficult things to do. Learning about the risk factors. Can we have a prediction? Now we are in an era of artificial intelligence, aren't we? Thinking about and predicting what is coming tomorrow. Can we have some predicting factors and risk factors that could point us to which patients will get the spasticity, which patients will get a problematic spasticity, so that we can proactively treat them? And understanding a brief understanding of management of spasticity and options. Then we're looking into, this is an important slide. As we know, spasticity happens at various time scales after developing into any neurological injury and in particularly with the stroke. That in a way is a problem for us. Because if we know that every patient who develops spasticity develops within a month, I think probably we can proactively look into that and manage them promptly and effectively. But because we know the paralysis, the weakness happens at the time of neurological damage, while the tightness of the muscle, spasticity, develops at a varied stages, very time scale from the time very early on, any day as one day till a very late in life or very later on following the stroke. And patient can develop disabling spasticity even as late as 6 months or as early as one day. And that actually brings us a little bit of a complications how we can identify this spasticity on early on in their journey, not since the stroke, but in their patient journey from the occurrence of spasticity into the before development of complication. How can we capture that and manage that proactively? That's going to be a little bit of a difficult and need to have thinking. And we know the phases of stroke: hyperacute, acute, early subacute, late subacute, or chronic, depending on whether from the zero, that's at the time of your stroke, till after 6 months or so. And the development of spasticity can happen as early as on the first day till to the late as well. And we already, Dr. Wayne has kindly mentioned about the development of a spasticity and development of a severe disabling spasticity can vary from very early to very late. Then we know that spasticity can happen early. There are certain risk factors which we identify early, even before developing spasticity. We can predict that these are the group of patients we have to watch carefully because they can develop into a severe spasticity requiring pharmacological management. That means in intervention not only by a physical therapy but also with the medication interventions. Delays in diagnosing and managing spasticity can lead into irreversible complications. So, essential is an early and a prompt intervention. Identification and intervention will reduce the risk of any complications and improves the patient outcome with patients with the neurological damage, in particular with the post-stroke spasticity. So, what are the risk factors? So, if you're looking at the baseline, let's assume the first week of the stroke. You are a clinician engaging with the patient's management in the first week of patients following a stroke. If the patient has a severe paralysis, so severe paralysis means if you're having a power of less than 3 and patients having an increased muscle tone, that's a modified Ashworth scale more than 1, or a modified moderately increased, so you might see that mildly increased, moderately increased, or markedly increased. That means modified scale of 1, 2, 3, or 4. That's what we are talking about. Can lead into severe spasticity. Hemihypostasia, reduced sensation on one side of the body, the affected side of the body, can lead into spasticity. Low Bartel scores or EQ5D can also contribute. We know that these are the risk factors. At any time, if you are a clinician, you're dealing with a patient with a stroke, not early time, not on a first week, but in a post-acute phase, then if you're looking into patients with paralysis, that's a weakness, or if you look into their medical records and say they had a very high severe NIHSS scores, low motoricity index in particular, low Bartel scores, left-sided hemiparesis, or history of smoking, hemiparesis and low Bartel score, or an extensive stroke lesions in a corticospinal tract based on a CT or MRI results. If you say that and you put them together, you know these group of patients will get a spasticity, will get a muscle tightness severe enough to impair their functionality, and you need to manage them proactively. So what could happen? We are aware that if the muscle is tight and not allowing the move the joint across and held the joint in a tight position, that can lead into structural problem, including contracture, bony fracture, all sorts of things from the skin into the bones. It can impair the most importantly the functional problem, whether it's active function, passive function, or even a symptomatic pain and discomfort, and even psychological and psychosocial problems. It can lead into, because of the immobility of a joint and the muscle, can lead into multiple medical problems. So you can may be difficult to quantify, but that is known to have that problems. Then the second problem is we understand that it can happen early. We understand that can have a severe complications, but how long does it take from developing of a tightness into complication is another question we need to answer. So before that, if I need to put it all together, so if I do a clinical examination of a patient at any time, if the patient has a dense weakness, if they have a loss of proprioception and the light touch, have a cognitive difficulty, especially the visual inattention and the perception and memory issues, these are at-risk group of patients developing into spasticity. So what we done is in around 2016 or so, a group of international clinicians got together and said that, can we simplify it? Can we say that if there are 100 patients come in, we cannot practically possibly do it in any healthcare system, that how are we going to follow them up on every day, because they will be in hospital in an acute setting, but they might be loose to follow up or might have a gap between inpatient to outpatient care. How can, it's easy to say that do it in early and promptly, but how can we identify? Then we decided we'll put all this together, put it in a traffic lights type of system, post-stroke spasticity referral tool, and do that. So in an essence, after reviewing all the evidence as of right now, we said that if the patient had a tonal change of a moderately, markedly, severely, that means modified Ashworth scale of 2, 3, or 4, increased muscle stiffness across 2 or more joints, that causes functional impairment or a problems treated active or passive motion, and they have a severe loss of sensory motor function, they will be at extreme risk of developing spasticity and they need to be seen ASAP. And with the interest of time, I leave those other slides there to say that if the patient has a loss of sensitivity, weakness, and the corticospinal tract, then these probably need to see as an outpatient. In a simple format we utilize in our hospital, if the patients trigger red, then we will see them as emergency, as an inpatient setting for a pharmacological, that's a medication thinking. And if there is an orange, we will continue with the physical therapy, that is a physiotherapy, OT, splinting, and then see them as an outpatient as soon as possible. And if it's a green, we'll continue with the physical therapy. There are a lot of resources available, whether you're talking about post-stroke checklist, you're talking about the management of spasticity after stroke checklist and this HCP and patients' lived experiences, or a screening tool, or a referral tool. So there are wide varieties of resources we can utilize to identify this patient. But in a real life, we need to be aware of what are the barriers, what are the things which could prevent us or delay in diagnosing. In three ways: it may be a system issue, maybe from a clinician issues, maybe from the patient awareness. So patient may follow lost to follow up. Patients or caregivers may lack education and are not aware of what is the spasticity and can lead into complication. We as a clinician may not be aware of all of them, so need to be having improved awareness across the spasticity and how that can impair patients' functionality and patients' progress in general. And obviously, there is a lot of systematic improvement we need to do in about excess of the rehabilitation and some spasticity services. And we talked about one thing: the complication and the time to complication. It can be as soon as 4 weeks from the time of starting of spasticity. They can develop into 4 to 6 weeks. They can develop into complications, and one of the complications which are easier to measure is the contracture. But as we said before, there are multiple complications that can develop, which we neither as a clinician, neither we nor the patient want to experience it. And there are many of the very widely recognized treatment option, pharmacological treatment option, including botulinum toxin. And we know all the national and international guidelines says botulinum toxin is a very safe and effective medications when you manage the focal spasticity. And obviously, along with the multidisciplinary team input, and that includes physical therapy, occupational therapy, and so on. And we know the routine complications, what we need to expect out of the botulinum toxin as well. The two important thing when you are doing assessment of spasticity: proactively understanding when they can develop, what are the goals identifying to improve the patient outcome, and what do the patient want to improve. And the second thing is, how will you measure the outcome that you are doing the right thing? And because botulinum toxin will reduce the tone of the muscle, that is for sure. But the question is, how will that help the patient? That is something we need to discuss and identify a smart goal and find a method to measure the outcome and various smarter technologies. So, and I'm open for any questions. Please put it in the chat. But what I wanted to leave with one answer is there is a risk stratification. We can proactively and we can predict the patients who can develop spasticity, and we can plan for it. Thank you.
Thank you very much, Dinesh, for this wonderful talk. And now we're going to leave the questions to the end. I also invite you to write your question in the Q&A box. And now it's my great pleasure to introduce Professor Jussara Almeida de Oliveira Baggio. Professor Jussara is a physiotherapist and associate professor at Federal University of Alagoas, and also a Future Leaders Program Cohort 3 member. And Jussara will talk about current challenges and barriers in the management of post-stroke spasticity. Thank you so much, Jussara, for joining us.
Thank you, Otávio. Let me share my slides. Can you see?
Yes, we can see very well.
Oh, okay. Thank you. Thank you for this kind introduction and for inviting me. Very happy to be here. And today I'll be talking about the challenges and barriers in managing post-stroke spasticity, a very important topic. Okay. The prevalence of post-stroke spasticity varies across the studies, as we saw during the talk of Dr. Theodore and Dr. Ganesh. I have some numbers here too. It affects nearly 25% of patients within 2 weeks of a stroke, increases to 38% after 12 months, and can reach up to 44% in patients with multiple hospitalizations. This condition is often linked to pain, loss of range of motion, and formation of contractures, which greatly impacts in functional recovery, making personal care and mobility challenging, and affecting quality of life. Given this significant challenge, this significant impact, our first challenge is identifying which patients are at risk of developing spasticity. This is crucial as many patients are referred for spasticity treatment just after developing complications, contracture. It's very often, very common, and we need to know when and how. We don't have a clear pathway for when and how to conduct assessments effectively. So we need to discuss this. We need to know when it's the best time to access those patients, when to identify and how to identify. To address this, understanding the predictors is essential. The most predictors described in the literature include reduced sensory-motor function, lower activity of daily life capabilities, and younger age. These patients with these characteristics should be monitored closely for spasticity. This study, the SALGO study, investigated different models different models and variables to predict spasticity. And the authors found that model A3 and B4 had the highest predictive values, and any spasticity was best predicted with variables collected at day 10, and severe spasticity was best predicted with variables collected at week 4. However, this period between 10 days and 4 weeks marks the transition of care from acute service to post-discharge service, and accessing these services during this period can be challenged and may delays in early identification of spasticity signs. The other question is how to identify, and we have seen some key variables to consider sensory motor function. It's a very important variable that we need to consider when we are accessing possible to identify patients who are at risk for developing spasticity. It's a very important measure, but we need to access and measure spasticity with reliable tools. So we have the modified Ashworth scale and the modified Tardieu scale. The Ashworth scale, it's widely used, it's easy and quick, but it's a subjective scale and has some limitations in measurement properties. On the other hand, we have the Tardieu scale that takes into account the resistance to passive movement at both slow and speedy movement, but it's a more time-consuming scale and also have some reliability limitations. It's also important to note that not all cases of spasticity affects function, so we need to take into account too. We need a reliable tool to access spasticity. We have to take into account other variables, and we need to access function, how this spasticity affects function. So we need a protocol, we need not just one instrument, we need a lot of pieces to think and to identify these patients. So this is the work of Dr. Ganesh. It's amazing work. To help clinicians, they has been proposed this traffic light model. So high-risk patients should be referred to a spasticity specialist. A medium risk patient should start rehabilitation and have a consultation with the multidisciplinary team. And if necessary, should be referred to a specialist in spasticity. And low-risk patients should receive formal education on post-stroke spasticity and be monitored. So this system is a very easy system to be implemented and could help clinicians to identify those patients. So our second challenge is the gap between the early identification and the patient access to treatment. So according to the WSA, rehabilitation is the less implemented pillar of care. And in Brazil, for example, this recent study showed that 1 month after stroke, 60% of patients access physiotherapy, 42% speech therapies, and only 17% occupational therapy. But Brazil, it's a continental country. It's a large country, so you have socioeconomic disparities. We have different realities. So here in those images, I have the distribution of neurologists in Brazil in 2023, and the distribution of physiotherapists in 2021. And you can see that we have an equal distribution of these professionals, and we have some areas here in the north and northwest of the country with insufficient number of professionals. So it's very hard for many patients to access treatment if we don't have enough number of professionals. A similar situations happens with the number of specialized rehabilitation services here in Brazil. We have an equal distribution, and we have some areas with no rehabilitation services. So it's not a reality of just in Brazil that happens that, but we know that low and middle income countries have a very difficult situation in the number of specialized rehabilitation service and the number of skilled professionals. In Latin America, this study showed that we have many barriers to access rehabilitation outpatient service, and the main barriers was the distance to rehabilitation facilities, the lack of rehabilitation personnel, and the lack of infrastructure. Even in high-income countries like Canada, patients face some difficulties to access facility treatments. So these studies show some examples. There are some financial barriers to covering botulinum toxin injections in some provinces in Canada, and accessing physiotherapy and occupational therapy can also be difficult in some provinces. And in Canada, a survey of specialists identify barriers in the patient journey. And two key issues are the lack of standardized process for assessment of spasticity in different parts of this journey, and the limited education of patients and caregivers on spasticity signs. So we need to improve that. It's two main barriers. This the standardized assessment and the lack of patient education. So the main barrier, it's the absence of the continuum of care, which negatively impacts in outcomes of our stroke patients. In addition to this, we have the implementation, the post-stroke screening for spasticity, the number of rehabilitation professionals, skilled professionals, the number of rehabilitation services, spasticity service, and the financial for pharmacological and non-pharmacological treatments. So we have been identifying those challenges and barriers in managing post-stroke spasticity. Now we need to consider some actions and possible solutions, because our main goal is to improve the quality of life and well-being of our stroke patients. In conclusion, we need to address our organizational aspects. We need to train healthcare professionals to recognize spasticity signs, and we have to secure financial support for adequate treatment. So establishing a standardized care pathway is essential for managing post-stroke spasticity. This is my reference, and thank you.
Thank you so much, Jussara, for this wonderful perspective on post-stroke spasticity. We're going to leave the questions to the end. We already had several questions now, and it's my great pleasure now to introduce Dr. Tamina Levy. Dr. Tamina is advanced practitioner, neurological physiotherapy, Division of Rehabilitation, Age and Palliative Care, Flinders Medical Center in Adelaide, South Australia. Senior lecturer at College of Nursing and Health Science in Flinders University. Tamina, it's a great pleasure to have you with us here today. And Dr. Levy will talk about optimizing prompt intervention best practices.
Thank you. Thanks for the introduction and for asking me to present today. I'm just going to say that Laura's controlling my slides because I've got some videos that seem to work better that way, so I'll be prompting her to move forward. And the other thing I might say is that I'm coming to you from gorgeous Adelaide, South Australia, where it's currently nearly 11:30 at night. So it's way past my bedtime. So hopefully I can get through the presentation. Thanks, Laura. So I'm going to talk to you about strategies for prompt intervention, the multi-D team and how important that is, and as well as that, talk about follow-ups and education. And I've got a great case study to really demonstrate, I guess, some of the things that have been coming through, the themes that have been coming through around early intervention and how that can have a really positive impact. So there is evidence for early intervention, and in that initial sort of 3 months, that sort of acute to early subacute phase where we've got the reorganization of the sensory motor network, this is the time that we are also getting potentially spasticity developing, and that really supports that concept that Professor Ween talked about around that sort of, it can be almost seen as like a post-stroke maladaptation. Now, at this time, because of paresis, involuntary muscle activity associated with spasticity can add to the risk of development of complications such as contracture. So what we're aiming to do during this time is really provide as normal sensory and proprioceptive input as we can to the disrupted sensory motor network as that reorganization occurs. But if physical management alone is not enough to sort of control that spastic motor movement disorder, we really need to consider early intervention. And that's, again, a message that you've heard loud and clear. So what we're really trying to do is get in before the impact, or before we get a shift from like a central nervous system type presentation to a sort of hardwired peripheral presentation where we've got the muscle stiffness, the tendon changes, etc. And we know we can actually slow that contracture, and there's been some studies that have looked at early intervention and the effect on contracture. There was one by Cameron Lindsay in 2021, which showed in upper limb that if people had early intervention with toxin and therapy, that would slow the rate of contracture formation. So we can have an impact. So the benefits of early intervention, we're avoiding complications, we're blocking that involuntary muscle activity, but really importantly, we're facilitating rehab and hopefully improving outcomes. And I think just to add here that sort of early prediction that we've been talking about is really important. So we need to identify these people early. Thanks, Laura. I think if we look at some of the trials where there hasn't been a positive effect with spasticity treatment, we can learn a little bit more about the course and implications of spasticity and contracture. Evidence does show us that contracture like spasticity can actually develop early, from even as early as 2 to 4 weeks. And obviously it will worsen over time if it's not managed. One example is the INTENSE trial. So the INTENSE trial was a large multi-centre trial in Australia, and it was a randomised controlled trial, and it was patients who had upper limb spasticity. Everyone got toxin to muscles that cross the wrist. The control group got a sheet of exercise. The intervention group got intensive therapy, which was 2 weeks of serial casting and then 10 weeks of motor retraining. So pretty intense therapy. But despite all of that, the main outcome, the primary outcome measure, the box and block, there was no significant difference. So this was really interesting. But when you looked at the population that was in this trial, so their mean time since stroke was over 3 years, so very chronic, and they also had a very high level of disability. So 80% of them couldn't actually pick up one block on the box and block. So really that window of opportunity of that neuroplastic change that we talked about had closed for a lot of those people. So that was interesting. Now, I went to this rehab conference in Sydney this year, which I'm sure a lot of people on the call probably did. And there was a group of spasticity experts who provided a workshop, and they presented this framework of the 3 C's, and they talked about sort of impaired command. We know that's happened when someone's had a stroke. This dysregulated control, which is more relating to the indirect pathways, but then importantly, this aspect of diminished contractility. And maybe they were saying that it's probably this, or likely to be this, that's really impacting whether someone will respond or not to treatment. So we've got to do everything in our power to prevent that from happening. But it's a challenge, and especially in the acute setting where the patients are so unwell, there's so much other stuff going on. And I know one of the presenters talked about, introducing that assessment of spasticity into the acute setting. But I mean, that would take a big change, I think, because I think there's so much else going on at that stage. But we should, as early as we can, we should be starting to do these assessments and keep our eye out for these patients, thinking about some of those predictive factors that a couple of the presenters have talked about. I want to highlight it's a real team approach. So it involves lots of education, skill development, and it's really important to see these patients together and make decisions collaboratively. So by that, I mean the medical aspect, like the neurologist or the rehab specialist, the physio, the OT, the patient, the family. It should be a decision or a conversation that happens with everyone involved. And, everyone should be respecting each other's opinions, and hopefully people are on the same page. And I think I'd just like to say, with my allied health hat on, that, it is often the allied health team members that see the impact of the spasticity more than maybe the medical do, because they're having their therapy sessions and doing their functional work. So I think that, our role in those conversations is really important. But I'd like to just, that key question that I think we need to keep asking at that point is, is the spasticity interfering with the progress in rehab? And if it is, we really should be intervening. So clear communication and education is really important. And just to highlight again, so we know it's never just spasticity, and we know that for many patients, the bigger problem is often the weakness. So we need to be addressing everything, with spasticity being one component of that. But I guess this is where that patient self-management comes in. So, if we're trying to get people to do a lot of intensity of practice, which we know has evidence particularly around the motor weakness, we can't do that in our health services. We don't have the capacity. I'm not sure what other countries are like, but certainly in Australia, we can't see people for what would be considered the ideal amount of time and intensity to make that, hopefully promote that change. So we need people to be involved. We need to set people up with really good programs, supported by their carers ideally, so that they can get that sort of practice going. And the other point here is really follow-up so important. And I think that's, that really depends, what the follow-up looks like really depends a bit on that risk level. So, if someone is low risk, but you still think they're a slight risk, then obviously that sort of follow-up would be obviously less than whether they were considered high risk, had a modified Ashworth of more than 2 at over, more than 1 joint. So those risk tools and concepts are really important when we think about how we organise follow-up as well. So now I've got a case study to present. So this gorgeous young lady was, she's actually originally from Colombia. So she's 32, very healthy previously, so no medical history. And she was on a bike ride with her husband, and then unfortunately he sort of turned around, she wasn't there, and found her on the side of the road. And she'd had a really big, significant right side stroke. So this was almost a year ago. So we got her onto it's called the Tobruk ward, which is our stroke ward. And she came in 1 week after her stroke, which was amazing. I mean, we don't always get them that early, but it was great because it meant we could really do a really great assessment and pick up on some of these issues from a very early stage. As you can see this is a summary of her assessment. It was a very dense stroke. So she had 0 out of 5 on her left side. She had very poor head control. She had a neglect, already had spasticity. So this is 1 week after stroke, already had spasticity in flexors in the upper limb. She actually had clonus bilaterally, and then she had some quad spasticity. But she also had a lot of really good things. So, I think sometimes we get fixated on the deficits, but she was young. She had some of her systems were spared. She had communication, although she was very drowsy, and an amazingly supportive family. So that was really positive. So the video is just really, this is to show you kind of that she, the sort of level that she was at the start. So this is probably within the first couple of weeks. You can see how hard it is for her to sit upright and trunk control, and she looks very drowsy. So there's three of our clinicians there. They're in their Christmas scrubs, so they can see how lovely they look in their lovely bright colours. And then on the right there, she's on the tilt table, just trying to get some activity through that left side with some work on her left leg. We might keep moving just for time. So at about 8 weeks, she was going really well, but we could see that the spasticity and spastic dystonia was really starting to impact her. So this was really around in her leg, losing confidence around walking because her ankle was rolling. And in her hand, she was really struggling to participate in her therapy, but also in any sort of self-care, functional work as well. It was really getting in the way. So we met as a team, had a discussion with her and her family as well. And at 9 weeks, she had intervention. You can see it's a really low dose, but that was because the family wanted to be cautious. And, you know, there is evidence if you go early and you go lower dose, you can still have a really significant impact. So this was her first round of treatment. She subsequently had 2 more as an outpatient, but this is her first round. She had toxin into tib post and then elbow and finger flexors. And then I think we've got, so this is her from her assessments in the left column. You can see she's got, so on the left, sorry, in January, she's got a modified Ashworth at the start of 3 in her elbow and her fingers. And you can see the FAST, which is the catch, the R1 on the Tardio scale, is at -45. So what that means is that if we're measuring her PIP, you know, that's sort of 0, and then she's getting a catch there at -45. So you can imagine if she's trying to open her hand and she's getting a catch there, that would really impact her ability to open her hand. So she's had the toxin, and then you can see her follow-up measures on the right, a really significant change. So her modified Ashworth is now 1, and then she's actually hasn't even got a catch in her fingers and minimal in her elbow. For the dystonic patients or the patients who have any dystonia component, we always do a video as well, which we've got coming up. And on the next slide, we've got her goal attainment scales, which we'll whiz through, but she had goals of reducing tremor, opening her fingers and being able to extend her arm. And then you can see post-injection, she's achieved a +1. I haven't got the measures for lower limb here, but basically the goal was around her ankle rolling when she was walking, and it was a successful treatment as well. So we'll just go on to some videos. So the video on the left, so this is her before the toxin. So she's being asked to open her hand and also to reach her arm forward, so extend her elbow. So you can see that sort of spastic dystonia in her hand there, and just how difficult it is for her to extend her elbow. So now if we look at post-toxin over on the right. So the other video, Laura, thanks. Laura, is that video playing, the second video?
It should be playing. It's playing on my screen.
It's not playing on mine. Is it playing on everyone else's?
Yes.
No,
Oh, there we
go.
go. Sorry. Yeah, just took a while. Maybe stop the other one. This one might catch up. So you can see now she's got much better ability to reach, and she can open her hand. She's still got that sort of spastic dystonia, but, you know, a much better hand posture and ability to sort of reach and grasp. So that's a really positive for her in terms of her function and her ability to continue her rehab. And then if we go to the next slide with a couple of her walking videos. So this is the first sort of gait video we've got of her. We might play it a couple of times. So this was early on. And obviously the clinician is doing a fair bit of assisting there. At this stage, she had very little active movement, and that spasticity in her quads was probably actually being helpful. Now, if we play it one more time, you can mostly see that E version on the sort of second to last step. If we just play it one more time, I'll just point out when to look for it. So, sorry, it's just playing a little bit slow motion, but it's not too bad. So this step here, as she plants there, you can see that E version as she puts her foot down. So this was impacting her because she just lost all her confidence as far as doing her gait retraining. She was really keen to do as much as possible, but she was just really worried about her foot rolling. So this step here, there you go, you can see that there. And that really impacted her, you know, wanting to do more gait work. So then if we stop that video, Laura, I think, and just play the next one. So this is down the track. This is obviously not just from having tib post injected, but what having tib post injected did for her was it increased her confidence, increased her ability to participate, do all the practice, work on her strength, and as you can see, an amazing outcome with her gait, which is so good. She's such a champion. That's great. Thanks, Laura. So my takeaway messages: assess and treat early, consider impact on rehab, getting in before those secondary changes. A team approach is really important. And that's just a little snip from a paper by Gavin Williams, which was sort of a synthesis of a whole lot of guidelines and reviews, which really talks about this integrated holistic approach that we need to be taking. And next slide. My references and acknowledgement of my fellow physio Nadia and the gorgeous patient that allowed us to share these videos. And just to say, yeah, come to Adelaide. We've got beautiful beaches and a lovely city and gorgeous wine. Thank you.
Wonderful, wonderful lecture, Tarina. Thank you so much for sharing such interesting cases. And now we have time for several questions. We had several questions in the Q&A. I'll try to address the first ones for you guys. So the first one came from Sami Mohammed. He asked, is there a similarity in the clinical features of those with post-anoxic brain injury, post-cardiac arrest, spasticity, and stroke? Can some of you address this?
Well, I think the patterns of spasticity may vary. Of course, with stroke, you're going to have focal spasticity, whereas with anoxic encephalopathy, you'll have a more diffuse pattern. There's a little bit more extensor posture, and perhaps Tamina and Jisara can comment on the patterns they see more often. As a stroke neurologist, I don't see a ton of anoxic encephalopathy, but it's your approach to it, because from a toxin perspective, you're limited, and with anoxic encephalopathy, you usually have a much more diffuse pattern that needs to be addressed.
All right. We have another question here. Can we offer any help for pre-existing contractures? And also noted for different types of locations and brands of toxin, botulinum toxin, how can we manage that? I think this is another question. Let's focus on the contractures now. Would you take
yeah, I'm happy to just have a little go at that. So I guess the options we've got for contracture are serial casting. The evidence for serial casting is sort of similar to Botox in that it will have a short-term effect, but it will bounce back if you don't then get in there and do all your motor retraining and stuff like that. But then if it's persistent contracture and it's not responding, then I think the other option is to look at surgical referral as well.
And I'm just going to add on to that. I think the surgical approach to spasticity is something that's underutilized around the world, and it's also very technically dependent on what resources you have. There's also other techniques such as cryoneurolysis that you can think of, and dry needling is usually less effective in contracture. But I do encourage everyone to try a course of neurotoxin before you call something a failure in the initial trials. people with contracture were included, and there was response, perhaps not as pronounced. But again, I think when you treat spasticity, it's not the doctor's opinion or the physiotherapist's opinion. I think an interdisciplinary approach is really essential to try to maximize outcome for your patient, including surgical opinion.
All right. So I think we have now a question for Jusara, and maybe Ganesh also could help. Are there any national programs in any country providing botulinum toxin for free? Could you comment that on the Brazilian perspective, Jusara, please?
Yes. So here in Brazil, we have botulinum injections for free in our health systems. Here in Brazil, we have a universal health system. So in most of times, these kind of injections, patients can get access in rehabilitation service. So there is a link between rehabilitation, the physiotherapy, the multidisciplinary team, and the accessment of a neurologist or another doctor specialized in rehabilitation medicine that can access and measure this facility, and the patient can get this injection for free in Brazil. It's not so easy. Sometimes it's not so accessible, as I said in my presentation, but it's possible. It's a reality here in Brazil.
All right. Can you comment, Ganesh, about Canada?
No, yeah, I work in the UK, and
sorry.
United Kingdom NHS is a National Health Services is a free for all, and
All right.
so it is they do not pay for healthcare services. However, there is a private setting as well. If you want to reach faster or want access differently for private, there are private provision. But in general, it's a free service, NHS.
What about Tamina and Theodore?
So in Canada, the National Health Service will cover botulinum toxin for free. You may have to pay a mild deductible, so $50 to $100 is usually the maximum you would need. So the toxin is available and there's people to inject it. Unlike Australia, which has a wonderful rehab system, in North America, you have limited access to adjunct services such as physiotherapy and occupational therapy, which I think are a key component of this. And I guess what I'm trying to stress with my previous comment, that a multidisciplinary or interdisciplinary approach is needed for spasticity, not just a magical injection or not just a physiotherapist, but we all really need to work together.
All right. Tamina, would you comment?
Yeah, so in relation to, sorry, is that in relation to the cost?
To the availability of free toxin, do you have?
Yeah, well, I mean, obviously there's the PBS criteria, but still, if people come through our health service, which is a public hospital, they have I think it's a tiny little charge, like literally $7 or something. So it's close to free.
Right.
Yeah, and we try and make sure we organise that kind of therapy follow-up, whether that's through our service or referring on to other services as well.
All right. I think we have several questions. Unfortunately, we won't have time to address all of them, and I would those questions will be addressed on the chat as well by the speakers. And later on, I think we have time for one more question. One question about acupuncture and dry needling. Can you give a perspective on your perspective about these techniques?
Yeah,
So,
I mean, sorry,
go ahead.
I work with another physio that does dry needling. I think she's probably listening in, who does dry needling, and there is definitely some evidence around dry needling now. I personally haven't done that myself, but there is some evidence around it.
So I'm just going to add on, because I actually currently have a grant doing a randomized trial of dry needling versus botulinum toxin. So hopefully we'll have an answer to that next year. In Zaragoza, Spain, there's an excellent group of dry needlers who've shown in their data to almost have equal efficacy for dry needling in select patients, obviously. But there is a randomized trial going on right now. So maybe next year we can have the same talk with those results.
right?
That
And
will
the
be
last,
really interesting because
okay.
I often think, you know, the patients that come in and say, as soon as they've had toxin, they say, oh, it feels better. Often think that's more that kind of needling effect.
So absolutely, I'd point out that in the botulinum toxin trials, the placebo group usually has a 30% response rate just to injecting normal
Yeah.
saline. So I do strongly believe there's a component to it, and we'll see, because it may be an alternative therapy as an adjunct or to add on to our patients to give them a better chance of recuperation.
Well, guys, that's great. We had a great discussion, some wonderful lectures. Unfortunately, our time is out. I would like to thank all the speakers for the excellent talks. And also invite everyone to follow up on our content on the World Stroke Academy. We have a lot of wonderful content there, and also would like to invite you to for the next webinar. We have a wonderful webinar with the key highlights from the World Stroke Congress in Abu Dhabi. We're gonna have wonderful presenters that will discuss the most important topics of the Congress. And that's it. I would like to thank everyone. Thank you, all the speakers, for this wonderful webinar. Thank you so much.
Thank you.
Thank you.
Good night.
Thank you.
Bye-bye, everyone.